I'm Peter Block at ACC.11, and with me is Bob Bono from Chicago Northwestern. He's professor of medicine. He needs no introduction. Everybody knows Bob. Bob, the STICH study. Interesting study having to do with surgery versus medical therapy for ischemic cardiomyopathic patients. What was the study about? What were you really looking for here?
Well, this is the first randomized prospective trial to look at this subset of patients. All the prior studies of CABG versus medical therapy excluded patients in heart failure with low ejection fraction. So all of these patients had ejection fractions of 35% or less. And it's essentially a combination of a revascularization heart failure kind of trial. And all patients received very aggressive medical therapy with or without CABG. So it's the first trial to do that. My sub-study of that, working with the STICH investigators, was a study looking at whether viability testing, myocardial viability testing with SPECT or with dobutamine echo, helps to identify patients who will or will not do better with CABG compared to medical therapy.
Well, let me interrupt because it seems to me that that's what we do all the time. We check to see if there is viability, and then if there is, we say, this patient probably should be revascularized. So what'd you find?
Well, every patient's got viable myocardium. They're alive and they've got hearts that beat, and so there's always viable myocardium there. The question is there a certain degree of viability that would or would not make you want to revascularize? And that's kind of what we were after. Our data show that viability testing does matter. The patients who have more viable myocardium have a better outcome, lower mortality and lower mortality plus hospitalization in a univariate analysis. But when you bring in everything else we know about our patients regarding their ejection fractions, their ventricular volumes, and then clinical factors like diabetes and renal function and age, all those other factors in a multivariable analysis make viability less important in predicting outcomes. So in a multivariable analysis, the viability tests were not significant. And then when we looked at the impact of viability testing on medical versus surgical assignment, again, in a multivariable analysis, there was no interaction, no significant benefit there. So
are you telling me, Bob, that all these tests, that all these PET scans that I've been doing and all these NMRs to find out whether there's viability are a waste of money?
Well, if we get into that realm of whether we're doing too much testing and whether we need to understand where it fits in, I think it's an important point that we do need to understand where diagnostic testing for cardiovascular disease really does fit in. Where do we get the bang for our buck? I think the point I'd make would be as follows. Suppose you have two patients, one's 60 years old, 3 vessel disease, good distal targets. We're going to revascularize that patient. I don't think we need a viability test, because even if it's negative, I would still revascularize. 80-year-old, prior bypass surgery, poor distal targets, diabetes and renal failure, well, then we might want more information. And so there could be some subsets of patients that we haven't yet analyzed where that kind of information could be very important. And I, as a clinician, trial or no trial, might want that information anyway.
So still a lot to learn from the data that you've generated, probably more to come, but interesting findings for now. Thank you, Bob.
Thank you, Peter.